Sitting in the sitting up position, you'll notice that they started with the posterior back. I'm going to do a few more things that you would always do when you're at the back, because you don't want to palpate and check for CVA tenderness when you've already done the exam and then get the person sitting up again and waste time. So when I go to the back, I'm doing two things. I'm looking at how he's breathing. I'm looking for accessory muscle use. So I would be concerned about the sternocleidomastoid muscle, the intercostals, and all of these neck muscles. Now, we don't see intercostal retractions, we don't see intercostal bulging, and we don't see your neck muscles pulling the chest up. So he's eupneic. Eupneic means normal breathing. Now, as I go around to the back, I'm checking the AP transverse diameter, which on him is 1 to 2. I don't have to measure this. All of you can do this visually. Now, could you do me a favor?
Sure.
And rotate your legs to the wall? Now, this way you can see what I'm doing. This patient comes with blue marks to tell you exactly where the lungs descend to. All right, so this is the fun part. Come on in. Now, what's interesting here is that, first of all, I'm going to inspect. Now, I don't see any obvious spinal deformity. I don't see any kyphosis. I do see a loss of some of the convexity that we would expect in the thoracic area, because your spine is actually has an S-shaped curve. So first of all, I've done my inspection. I don't see any skin lesions of concern. And now I'm going to palpate. So the first thing I do is, now this is actually musculoskeletal, is I palpate the muscles on either side of the spine, the paracervicals, the parathoracic, and the paralumbar and sacral. Now, if that doesn't elicit tenderness, that's good, but sometimes it does. Now, the other thing I'm going to do is I'm going to check for fremitus. Can you say 99, please?
Sure. 99, 99, 99.
Now, the fremitus
99,
is diminishing
99,
in the periphery.
99.
So fremitus
99.
diminishes in the periphery. Now, another thing that I want to do is I'm going to double check for costal vertebral angle tenderness. Now, the kidneys are going to be about here. So what I do is I have one blunt blow to each side. Now, if he had pyelonephritis, where you have an infection of the kidney and it's stretching the capsule, that hurts. So that would have elicited tenderness. So to resume, we've done palpation of the parasternal muscles, we've done fremitus, and we've also done CVA tenderness. This is thoracic excursion. 2 lips. Inhale, exhale. Perfect. Okay, so thoracic excursion is symmetric. Now I'm ready for percussion. Now the apices are here, so I'm going to do 3 blows. I purposely stay away from muscle. Now this is his C7, here's his T1. So I can really easily feel his intercostal spaces. Now listen to this resonant note. Now notice how I shift my hand. I'm going to go down 2 ICSs. I'm glad I found you in this state because it's very helpful. Now here below the scapula, which is going to be at about T7, the ribs flatten out a little bit. So whoever drew these artistic blue lines had the right idea. Now, inhale please, and hold it. Listen. There you go, thank you. Exhale and hold it. Okay, now breathe. This is actually where he expands to. So this is his diaphragmatic excursion. You actually heard the sounds yourself. Mm-hmm. Now it's more natural for people to inhale and hold it and exhale versus exhale and then inhale. Mm-hmm. So that's how you do diaphragmatic excursion. Now down here, notice that my finger's a little bit flatter. Now I already have an idea of how far down his lungs go. This is super. Okay, so he has good diaphragmatic excursion and he's resonant to percussion. Now, could you breathe slowly with your mouth open?
Sure.
Okay. Now at T3, we've got the division between the upper and lower lobes. So big breath. Okay. Has anybody noticed that you do side to side and then you drop on the same side? Then over here, now I'm going to drop. That's what I'd like to see when you do all of your exams. Good. Vesicular sounds all over the lungs, except for bronchovesicular sounds, which have a 1-to-1 ratio. These are vesicular sounds over small airways, alveoli, and so they're going to have a 3-to-1 ratio. Now, choose a voice sound. Could you say E for me?
E, 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 E.
So no E to A changes, no consolidation, no adventitious sounds, no help, no stridor, no crackles, no rhonchi, no wheezes. Hey, that was terrific. Now you saw the people in the video doing this type of palpation. This actually focuses on different structures than what I was focusing on, but in real life, people have a lot of back pain, and when you move the paraspinals the way I did, aren't you really moving the same muscles? You're eliciting the structures underneath, not just the muscle, but any musculoskeletal pain. So you really are getting to the same thing. That's the exam. Now the next step would be have him to lie down. Now have a seat here and then lie back. I'm going to show you jugular venous distension. Well, of course, since I'm so respectful of my patient. Now, we're going to have to do something with these very long legs. Here we go. And long, I mean it.
Oh, sorry, Rick. No, you're good.
Oh, no. And actually, I can't believe it, that we can actually get tangential light. Remember I said I was going to show you how to do JVD when it was relevant? Anybody who's sitting up the way you were, who had veins that filled up to the angle of the jaw would be in big trouble. They would have serious volume overload or probably right-sided heart failure. Well, the thing to think about here is this is the optimal time to do the exam because at 45 degrees really, you should not have any JVD higher than 2 centimeters. So could you get me a little ruler in there? Okay. Now I'm actually going to be going back there to help y'all out there. Now, if you just turn your head a little bit to the left, now come on up because I want to show you something. Now, if you go from the angle of the jaw to the lateral third of the clavicle, which is here, if you look right here, we see a vein undulating as it fills. Now, just for a party trick, and this is not part of your final exam, will you just please do a little Valsalva? Just push down.
On waiting.
Okay, you can take in a breath and hold it.
Okay.
Okay, now I don't know if you saw this fill up a little bit. It's more evident on my neck. Okay, let go, let go. Now this is all flat. Now the real place to check is actually right through here. Now here's the thing. Whenever you push down, you hold your breath, or for instance you're struggling with pain, the external jugular will always fill up. We're really supposed to read the internal jugular, which is here. But this is the one that fills up readily, so a lot of people read that. So let's say that the column of blood went all the way to the angle of the jaw. So what we would do is we would go to the sternal angle there, the sternal ridge, and we're going to measure this in centimeters. So what we do is we measure how tall is that column of blood. Now let's just say it was here. Now I'm going to draw a straight line. Now that, by my measurement, would have been about 5 centimeters. And you know that anything over 2 centimeters is positive JVD. That's not normal. So it's not difficult to do. And we've discussed some of the hazards of using the external jugular. Now I'm going to get on that table, and you can put yourself back together. And I am going to do my party trick, and you will definitely see what I'm doing. Now, oh, and I wore the right thing. Oh, goody.
Okay.
Oh, dear.
Step to
This
the
is
side.
someone's beautiful expo.
Thank you.
Okay. All right, now I'm going to do a little party trick now. Notice from the angle of the jaw
You can put your legs
down
out
to
if
the
you need.
lateral third. Good. I'm glad you didn't get out the potty.
Really?
Okay, here we go. Did you see it here?
Yeah.
Yeah.
Yes?
Yeah.
And it went all the way up? Oh, good. Okay, now, here is the angle of Louis there. Now, is the little measuring stick not there?
Yeah, it's right
Yeah.
here.
Okay, good. All right, you're the filmer. Come on over here. Measure it. Okay, now, if it goes all the way to the angle of my jaw, how high would that be?
To your angle of your jaw, that would be
Okay, so,
10.5.
oh, I don't think so. No, draw a straight line like that.
Eight.
I
9.5.
really think that.
I think like 7.
Isn't it closer to 5?
Wait, inches or
Mhm.
centimeters?
Centimeters, of course.
Yeah, I'm looking at this side. I'm looking at the inch side, so
Isn't
I
it
can
closer
see it.
to
Yeah,
5?
put it
Check
like
it.
against
Yeah, it's like
tangential, right?
7.
7, okay. Am I sick? I'm sick. Okay, but look at my neck again without the party trick. And notice that we have this vessel, but if you look right here, there's another little vessel that produces a kind of a rippling effect.
Like all the time.
Yeah.
Yeah, I
It
see
does
it doing
this.
it all the time.
Yes, it does this. That's a vein. And every one of those little ripples actually corresponds to something in the heart. Like one is atrial contraction, one's ventricular contraction. Now, in contrast, the carotids always pump up like that. So don't get those two mixed up. Now, what's really fascinating is when nurses are feeling the veins and they tell me it's a carotid pulse. That's not going to happen in this group, of course not. So that's where we're going to go next week, because the thing is that the anterior chest, now that you know all the landmarks, when you actually go to get the auscultatory areas, you already know where to go. Okay, now I'm going to do another one in the